I am Thygesenv2, professor of cardiology at the University of Aarhus in Denmark, and since year 2000 I have been the chairman of the Global Task Force on the definition of acute myocardial infarction. I have no disclosures. The universal definition of myocardial infarction come up in year 2000, where we have looked at the older WHO definition of myocardial infarction, which has been in force since 1950s. But the older definition of myocardial infarction was not so clinical applicable, and at that time we also have new biomarkers. That was the reason why we convened with a joint efforts between European Society of Cardiology, the American College of Cardiology, and later on as well with American Heart Association and World Heart Federation to compile a new definition. The first one appeared in year 2000, called the 2000 document. We updated the document in 2007, and again we have made a new update arriving and published in year 2000 in the major cardiovascular journals, in European Heart Journal, the Circulation, and the Journal of American College of Cardiology. Besides, it has been published in many pocket guidelines and had been translated to many national languages, and as well as slide sets you can find on the website of European Society of Cardiology. Well, we are talking about a new definition of myocardial infarction, and in fact it is not new. We have kept the pathological definition of myocardial infarction, saying that an infarct is if you have necrosis, myocardial necrosis because of myocardial ischemia. So what we are looking for when we define myocardial infarction is the two elements, ischemia and necrosis. And then we have converted that to a clinical application. So what we come up with in year 2000 firstly, and have repeatedly last time here in 2012, is that you should base a definition, you should have some marker of myocardial necrosis. And marker of myocardial necrosis or cell death is biomarkers. And here we recommend to use the new biomarkers, the troponin. But they cannot stand alone. We should have additional information, and we should have information about ischemia. Here we have the symptoms, is well-known symptoms for chest discomfort, dyspnea and others. In addition, or there should be some ECG changes indicative of ischemia. Here ST segment changes or new left bundle branch block, or Q waves as we always had. Besides then, we can have imaging signs of ischemia, new regular wall motion abnormality and similar. In addition, what we add in 2012, if there is an intracoronary thrombus by angiography or autopsy, that will also be a symptoms, of course, or not a symptoms, but a sign of something has happened in coronary arteries, and that would also fulfill the criteria for acute myocardial infarction. So what I said is very important for the universal definition of myocardial infarction to look for the biomarker values. We recommend to use a new troponin assays. There are many assays of troponin, but if the troponin assays is not available, then still the CKMB can be used, and we there recommend the CKMB mass. that is not new. It has been said that for years. When there is an elevation of biomarkers here shown as troponin, then there is also very important to be aware of that could be elevated because of myocardial injury or other reasons than ischemia. If there are elevation in the context of ischemia, we are talking about myocardial infarction. That could be myocardial infarction type 1, or there could be a type 2. I'll get back to that. And there could, of course, be other reasons where there's not ischemia. There's many scenarios or conditions where it could be injury, and sometimes we know the reason, sometimes not. And here is given examples of the different conditions where there is an elevation of cardiac troponin values. That, as is shown here, that could be when there is a myocardial ischemia. Then we have talked about myocardial infarction type 1. But if there are not a plaque rupture, then we have myocardial infarction type 2. And then there are many other conditions in the clinics where there can be elevation of the troponin values, but we should not call that for an infarct, but to call it myocardial injury. It's very typical when we are talking about myocardial infarction, and a criteria for that is that there should be a rise and or fall of biomarkers. But if you are have more stable or continuous elevation of biomarkers, that we talk more about other structural diseases where the myocardium is involved. Here is shown some of such condition where you have something happen in the myocardium, and that could be an injury. But if you at the same time will have an ischemia, myocardial ischemia, and rise and fall of cardiac troponin, then we talked about myocardial infarction. We know very well that in many other situations there could be some release of troponins or CK-MB-MRs if, for example, there's done some cardiac procedure, either major surgeries, arrhythmias, tachyarrhythmias, for example, heart failure and renal failure. There we often can observe elevated troponin values in the blood. That could be a myocardial infarction, it could just be a myocardial injury, or there can be other situations where there's no increase. Here again, it's important to look for if there's ischemia or not ischemia, or is there a rise and fall. Then it's myocardial infarction, injury, or not involvement of the heart. Then I'll go a little further into the definition of various classes of myocardial infarction which come up in the 2007 document and was continued and developed further in the 2012 document. The myocardial infarction type 1 is the spontaneous myocardial infarction where they observed a plaque rupture and a coronary thrombosis, and that is in fact you can call a classic infarct with coronary thrombosis, where we surely have a clot there, and all the guidelines that are directed against this myocardial infarction type 1. But it also appeared that in many conditions or scenarios we could have a myocardial ischemia because of an imbalance between oxygen supply and oxygen demand, where there is a condition other than coronary artery disease where there's not a plaque rupture. That could be spasm or other endothelial dysfunction given rise to this imbalance of that. And that has been, I think, more and more aware of that not all patients should be treated like type 1 myocardial infarction where you have the coronary thrombosis. Type 2 should be handled differently. Then we also have suggested having type 3, but that is for the cases where the patient arrived and perhaps died suddenly before the biomarker are available has never been drawn, because things are happening so fast. If they come to emergency room and there's ventricular fibrillation and the patient die, and they would have time to take blood samples. We suggest that should be called type 3. We know very well there not be many of them, but that at least there's a category to have them. Then we go into the area of procedure, and that is very, very much discussed, and there's a lot of controversy about this with this area. But nevertheless, we have suggested that if they are done a procedure, a PCI, and there is an elevation of biomarkers, we are thinking mostly about troponins, and this elevation are 5 times the upper limits of the decision level, then we should think about that something has happened in the myocardium. At least the elevation is a sign of the myocardial necrosis. But that could not stand alone. And in a document of 2012, we added that there should be other symptoms of ischemia, or it could be ECG change indicative of myocardial ischemia, or there could be some new echo changes, for example, new wall motion abnormalities. If all these parameters or variables are present, then it should be called myocardial infarction type 4A. Then there is the condition where something happens very acutely. There's stent thrombosis, and it's shown here on the slide clearly. And there, if you are at the same time have elevation of biomarkers, but here it's just the same decision level as the spontaneous myocardial infarction. In that case, this is called type 4B, or the stent thrombosis myocardial infarction. Further, we have looked for the myocardial infarction type 5, meaning that is the myocardial infarction related to coronary artery bypass surgery. And here we have elevated the bar from the previous document. Now in the document of 2012, we are demanding an elevation of 10 times upper limit. But again, it cannot stand alone. There should be other criteria for biomarker infarction, for example, new pathological Q-waves or new changes in the wall motion index, or if something angiography. So here is shown for the different types of myocardial infarction where there are different decision limits. The spontaneous or type 1, that is the upper limit of normal, and the upper limit of normal is 99 percentile of the upper reference level. It's the same with myocardial infarction type 2. We talked about type 3, that we do not have biomarkers. Then it was myocardial infarction type 4A, where elevations should be 5 times upper limit. Then is for the type 4B, where we have this, are demanded the same decision level as the spontaneous myocardial infarction. And then there was the CAPITS related myocardial infarction, where the biomarker should be elevated more than 10 times upper limit of reference. Altogether, what we are talking here is the classification of myocardial infarction. We think it is important to continue to have this classification, but we also are aware of that there are many different things we still could discuss and should be discussed. For example, how to differentiate between myocardial infarction type 1 and type 2. We need more work on that, more scientific data about that, how to do it. We also, is very important to come up with better data to distinguish myocardial injury from myocardial infarction type 2. We should also be a little better to define type 3. Some are it's been a little bit confused with sudden cardiac death, but it's not always that category. But at least the biomarker are missing, and also we should look more about the procedural-related myocardial infarction. Is a very, very hot debate about that. Should they in fact be part of myocardial infarction, or should it just be called myocardial injury, or which decision limits should be chosen? We have gone into that, raised said 5 times upper for PCI and 10 times upper for CABG, but that could discussed, of course. It was a consensus agreement. And that could be taken many other elements from the universal definition of myocardial infarction. Here I have shown the classification, but I could recommend you to go through the published documents where there are more about how to define myocardial infarction in other conditions, in heart failure, sepsis, in the coronary care or intensive departments, and in clinical trials. We have agreed. We have now the 2012 document, and we have just during the ESC Congress here in Amsterdam in 2013 had a meeting, and everybody, and that is worldwide, agreed that we should continue our work, continuously update the definition, because that is necessary. We know that the treatment is become better and better. We also know that there's some pattern of disease changes, and therefore we need also to look at the definition of myocardial infarction again and again, and perhaps we should look at other elements of acute coronary syndrome. Should we still have the disease called unstable angina? What with sudden cardiac death, how should that be defined? And how to define myocardial injury and necrosis in a clinical context. Thank you for your attention. The application was, and when we started the process in the year 2000, that was for the clinicians. And as you heard in my talk, that we have developed criteria to be used clinically. On the other hand, we also aware of that epidemiologists is not so happy with this clinical definition, because they have used very much in the past used ECG changes combined with symptoms. Of course, I have paid attention to biomarkers, but not so much. But we have invited epidemiologists to be a part of our task force, and they have also come with their input, as well as the World Health Organization also are involved, and in fact have accepted the universal definition of myocardial infarction, but at the same time saying that they are not so useful in resource-constrained countries. And for that purpose, we had meeting with World Health Organization to look there at the ECG criteria or electrocardiographic criteria, which always have been used by epidemiologists. So I think we have combined it very well, so epidemiologists can also make use of universal definition of myocardial infarction, but they have been, via World Health Organization, added some categories for use of ECG alone without biomarkers. Concern your question with health economic, that is more difficult to answer because they always follow some years after new definition as well. We think it is very important that the health authorities and other insurance companies pay attention to universal definition of myocardial infarction, and therefore we also in the documents have a section about that, how to do it, and then of course we hope that it will be done in practice.